It's my pleasure to be here to be part of the Congress. I've had a terrific meeting here. It's a pleasure to meet many new friends and to connect with many of my old international friends. As Catherine mentioned, and I want to thank you for that introduction, as the president of our hospital, I often critique my staff for bringing me problems, not solutions. So in my talk today, I'm going to do a little bit of that, defining a problem, but not necessarily presenting a solution about what I think is a growing epidemic of cardiovascular disease across the globe. I have no disclosures. The story of the last 70 years it's truly remarkable in terms of the effect of the treatments and strategies around cardiovascular mortality. This slide really depicts what the last almost 70 years looks like, with a 70% reduction overall in global mortality from cardiovascular disease. And much of that improvement has been driven by the treatments and therapeutic strategies illustrated in this slide. So everything from medications early on for beta blockers and aspirin for myocardial infarction, leading to coronary angiography, ultimately angioplasty, and now advanced treatments for heart failure and stroke, have made big differences in the cardiovascular mortality disease. But over the last several years, we've seen a bit of slowing of our progress. Much of the treatment effects of these different strategies can be shown in this slide. So this is an analysis of all the different treatment strategies over the last 50 years or so, looking at what's made the biggest difference. And what you'll see is about 50% of the improvement in cardiovascular mortality was driven by prevention strategies, and about 50% of it was driven by treatment strategies, things like revascularization for after myocardial infarction, therapy of heart failure, and revascularization for chronic angina. So the rest of our improvement has really been around prevention and both primary and secondary strategies. But you'll see at the bottom there the two items that are, I think, deserving of special mention, and that's the increases in BMI, translated as obesity, and also the concurrent rise in diabetes mellitus over that same time period. So this is what mortality is beginning to look like over the last few years. I'm going to show you throughout the talk United States data as well as world data, not because we're that different, but because I think much of the problem that we're seeing in terms of the global epidemic of obesity, diabetes, and hypertension originated in the United States. So we are sort of the zero case there, the spread of obesity and the concurrent hypertension and diabetes mellitus. But what you see here is with a reduction in mortality for cardiovascular disease of right around 4% per year over the last 10 to 12 years. And then right around 2011, we began to see a slowing of that cardiovascular mortality, which has essentially flattened out leading up to 2015. So here's the most recent data for both cardiovascular diseases. The next slide will show stroke. And you'll see here that gradual slowing, again, beginning around 2011 and continuing to 2015, first for cardiovascular disease and secondly for stroke. So in both cardiovascular disease and stroke, we've seen the first uptick in mortality since 1969. So those are worrisome events and worrisome statistics that suggest that the progress that we've made over the last 50 years may not be continued if we don't do something different. So this is a study commissioned by the AHA, data from that you can find on the AHA website around the global burden of cardiovascular disease. And what you see here is a prediction of what things will look like if we continue the pattern over the last 4 years as opposed to the last 50. And so you see that just in the United States alone, if we were to continue that slowing of progress, by the year 2035, 45% of the U.S. population would have cardiovascular disease, a number that translates very similar to what we see here in China. 42% would have hypertension, and the cost of this disease, which is not listed on this slide, would be, in just the United States alone, $1.1 trillion. So in many ways, what we need to do very much parallels my own life. So I spent the first 20 years of my life as an interventional cardiologist. That's me on the upside of the seesaw there, spending most of my time in the cath lab treating myocardial infarction, doing interventions around for patients with chronic angina. And now much of my time is spent around the world of prevention, getting out into health fairs, building health in our communities, and developing strategies, which I think is really going to be, and the investments necessary to change the health of a population. Not one patient at a time, but hundreds and thousands at a time. So I'm going to talk over the next several minutes about 3 things that I think are particularly important. One is tobacco control, one is obesity and hypertension, and also around diabetes as well, and the global epidemic that's occurring there. So this is quite a bit of data to digest, but if you look carefully at the categories here, these are categories of 3 longitudinal studies looking at the mortality, cardiovascular mortality related to tobacco use over 3 periods of time. CPS stands for Cancer Prevention Study. You see here a study in the 50s and 60s, a study in the 80s, and a study from 2000 to 2010 of 5 contemporary trials, which very much mimic those cancer prevention studies. And what I would highlight for you is both for men and women is that the cardiovascular, the risk factor, or the relative risk ratio around mortality for cardiovascular disease in people who smoke is going up and up. So you'll see the cardiovascular ratio there for ischemic heart disease in both men and women was 1.69 and 1.35 respectively in the 50s and 60s. Now, if you look at a period of time that's closer to where we practice now, 2.5 and 2.76. So just to highlight that we're getting sicker as a population, and the importance of tobacco control has never been more prominent than it is today. So that data is from the U.S., just to give you some flavor from a different, healthier population, but to illustrate the same point. This is data from the Norwegian county studies, looking again at people who, the overall mortality of that community in people 40 to 70 years of age. That's the blue bar. The red bar are people that don't smoke. The green bar are people that smoke but have stopped smoking, and the purple bar is people that continue to smoke. So what you see, even in a relatively health-conscious population like the Norwegian county study was conducted in, the morbidity and mortality associated with smoking has never been more prominent, and the opportunity there has never been greater. So the other thing that I think is sobering about the tobacco problem across the world is it's now becoming a disease of the poor and the less educated. So this is data from the CDC looking at the prevalence of smoking by poverty status. So you can see that if you're below the poverty level across the continuum, that the cardiovascular mortality is right around 26%. I'm sorry, the prevalence of smoking is 26%. And if you're above the poverty level, that's 13.9%. The same sort of goes with education. So you can see if you're someone who's less educated, someone who's below the level of a high school education, the prevalence of smoking is 25%. Whereas if you're someone who's likely to be in this room or attending this conference, the actual prevalence of smoking is more around 5 to 6%. So this is a changing demographic of disease that suggests that our strategies to impact tobacco control may need to be tailored to a population that is, for the most part, poorer and less educated than ever before. So strategies to reduce tobacco use or release, I think, should pivot around the data that I just showed you in the previous slides. Improving access to smoking cessation counseling and pharmacologic therapies to stop smoking, tobacco control policies, and decreasing the availability and affordability of tobacco. So here again is the prevalence of smoking across the globe. So lighter is better, darker is worse. The darker the color, the higher the prevalence of smoking. So just take a moment to digest this slide and see where the smoking prevalence is the highest. So you can certainly see as you move to the right of the slide there that says the countries that the part of the world that represents the highest prevalence of tobacco. So this next slide shows where the cessation programs are more concentrated. So it's the exact opposite of what we see the prevalence of smoking. The places where smoking is most prevalent have the least access to pharmacologic or behavioral counseling for smoking and is less supported by the healthcare reimbursement platforms in those countries. So in order for us to really impact, particularly the poor and those who are less educated, we've got to flip that graph and put more investment in those programs for people that are underserved in terms of addressing that important need. This slide is meant to show the relationship between smoke-free laws and coronary events. And that's an unreadable graph there, but if you'll just look at the continuum of the risk plots there, you'll see really a common theme is in order for there to be an impact of policy on tobacco use, it has to be comprehensive. It can't just be workplaces. It can't be just workplaces and restaurants. It needs to be public areas, which include workplaces, restaurants, and most importantly, bars. And if you look at doing all those three things, you'll see about a 15% reduction in the risk of cardiovascular events. And most of those events are new myocardial infarctions in that same age group that we were just talking about. 40 years of age to 70 years of age. The other thing that markedly affects tobacco use is price. And so if you look at these graphs, both in adults and in kids, adults on the top, kids on the bottom, you'll see that the inverse relationship between the cost of tobacco and the sales of tobacco products. So in order for there to be a real movement, we have to educate, or we need to have policies in place for tobacco control in public spaces, but also we need to have a focus on what cigarettes cost and the access to them, because in environments where cigarettes are more expensive and less available, less people use them. So next I'm going to turn my attention to the epidemic of obesity. You'll see the same thing again, starting with the United States, with the most obese country on earth, and we started something that seems to be spreading across the globe. So this is the prevalence of obesity again, with less than 10% being that lightest color, more than 30% being that darkest color. This is males across the globe, and here's females. So and this again is a look across the United States, just to show you the way this is progressing, which I think that we're now beginning to see across the globe. So this is the prevalence of obesity in the top, diagnosed diabetes at the bottom across the United States over 3 different time periods, 1994, 2000, and 2015. So you can see, starting in 1994, we certainly had a problem with obesity, but by the year 2015, you can see the percentage of the country, which is about 80%, that has a prevalence of obesity of greater than 26%, and you can see that almost the exact replication of that data in diabetes, with more than 2/3 of the country having a prevalence of diabetes of more than 9%. The story also has a health disparities piece to it as well, and that these are rates of prevalence of obesity among whites in the United States. So you look here at the United States for whites, here for Hispanics, and here for African Americans. So again, not only is there a gradient by geography, there's a gradient by race as well, which deserves more attention than we're paying to it currently. That's translated now into a number that's fairly staggering in the United States. So if you look at this is the percentage of the country with diabetes, which is right around, actually we're just a little about 1% overall in 1958. Now in 2015, with about 27 million people having diabetes mellitus, and again, like I told you before, close to 8% of the country overall having newly diagnosed diabetes mellitus. Hypertension follows the same thing. So this is that same analysis I showed you earlier, showing that just as obesity is on the rise, as is diabetes, hypertension is up. You can see by gender, males and females here. The overall prevalence of hypertension is just about 40% in the country, with that really significant rise, particularly in women, over the last 5 to 10 years. Same story about race, and I showed you that earlier. Again, we have the highest rates of hypertension in non-whites, and particularly in black populations. So that's the U.S. story, and I would say we started this. Sorry for that. Like many bad things from the United States, we spread over to other places. And this is that same trend looking at obesity through the world over the period of time from 1975 to 2014. So you see here all the countries listed in different colors in this graph, and you'll see is the steepest slopes of those listed both for men and for women in those first boxes there in this graph. And it's quite surprising. The biggest change is not what you would think. It's not in the Americas or in the developed countries. It's in West Africa and Sub-Saharan Africa. It's in Asia, both Asia and in Southeast Asia as well. But everybody's on the way up with those striking differences in areas where we traditionally don't associate thinking with obesity and the prevalence of hypertension and diabetes. Same story here with diabetes, almost the exact same ordering of the countries. Diabetes follows obesity. You see again those same trends in West Africa, Sub-Saharan Africa, and Asia and Southeast Asia. So here's that same bit of data sort of showed a bit differently here. So what this is an overlay of this first slide I showed you in this series, looking at the prevalence of obesity across the country. What I did here what I'll show you this graphic is took the change in the prevalence of obesity over the last 20 years across the globe. So I won't show you every country, but let me show you a few just to highlight what I showed you in the other points. So this is the U.S. here, the Americas overall, again showing increases in the prevalence of obesity that's significant over the last 20 years, But look at the areas that we don't traditionally think about and often particularly don't invest in terms of public health in addressing this important problem. China, even though the rates of obesity are very low, 910% increase over the last 20 years. Same stories, big stories in Japan, India, the Congo, again, sub-Saharan Africa there, Australia, a country we often think of in relationship to healthy environments, but also with the same disease that all of us had. Probably our colleagues in Eastern Europe and in the Middle East, again. So this is an epidemic that is not just spread in the Americas, but is really a now national and global epidemic. So as you look here, this is the association of that with hypertension. So this is a graphic representation of hypertension in a similar form to what I showed you. You'll see a couple of different things I've highlighted by the arrows. Again, those increases in global prevalences of obesity translated into hypertension, particularly in those groups that we don't traditionally think about. East Asia and the Pacific, particularly women in Latin America, South Asia, and Sub-Saharan Africa. And then again, if you look at the very first of that graph, again, it shows that same disparity we talked about with smoking, and is the high-income countries are doing better than the low-income countries in terms of the prevalence of obesity. So here are things that I think we're going to need as a nation and as a global nation to address. One is the access to and affordability of healthy food, policy support of exercises and safe places to do it, improvements in food knowledge through labels and other educational efforts, mandated food standards for school meal programs. Kids, they learn to eat, and so I think in my own life, as someone now who has about 15,000 employees and daycare centers and things like that, I'm always impressed by what the impact of what children are eating has on what their parents' choices around food as well. It's something I think we need to recognize and invest in. And finally, taxes and price promotion on unhealthy food and drink with the proceeds used to benefit health and wellness initiatives. So I'm going to close with what I think are a conclusion around what I've shown you over the last several slides. I don't want to leave anyone with the impression that we shouldn't keep doing the same things we've always been doing in terms of the secondary prevention of cardiovascular disease and investing in therapeutics. Things like primary angioplasty, thrombolytics for stroke, all those things have made remarkable differences in reducing cardiovascular mortality. But now I think we need to double down on our investments in public health and in prevention so we can begin to quell this epidemic, which is sweeping the globe. We certainly need more investments in smoking cessation, particularly focusing on cessation assistance for lower-income smokers, for those who are less educated. Smoke-free policies and tobacco pricing and taxes make a big difference on the price of tobacco products globally, and they impact the rates of use, particularly in kids. And finally, I think we need broad-based efforts on obesity, focusing on healthy, affordable food, policies which drive healthy behaviors, and focus on health disparities. So with that, I'll thank you for your attention and look forward to being with you for the rest of the session.